Today we'll be discussing about guidelines on iron therapy in CKD and a few points regarding FGF23 and iron. So, 3 to 5 grams of our body is made up of iron, and about 60% of it is made up of hemoglobin and 10% by myoglobin. Even though this iron is found ubiquitously in all over the environment, still this is the most common deficient micronutrient worldwide. And it has many roles: oxygen transport, energy production, DNA synthesis, cellular respiration. So apart from the anemia concept, the other extended roles of iron is probably due to the capacity that iron can undergo redox reactions. Redox reactions is where when an inorganic compound can donate and accept electrons whenever required in biological systems. So when iron deficiency occurs, yeah, definitely anemia will come out. So we know that during the erythropoiesis cycle, after the initial erythropoietin dependent part of erythropoiesis, from this part of proerythroblast onwards, iron is required for proper erythropoiesis. So whenever iron is deficient, the patient develops anemia. As I told earlier, beyond anemia, iron has other roles, especially the iron sulfur cluster. So there are a lot of enzymes in this cluster, and that is the reason why it is required for TSCA cycle, electron transport, DNA synthesis, and whatnot. So just going through the basics. So this is the proximal duodenum, where you can, this is the lumen, prostoduodenal lumen, this is the enterocyte, and this is the systemic circulation. So the iron in food can be of two types: heme iron and non-heme iron. The good thing regarding heme iron is it can be easily absorbed. There is a simple transporter. As soon as heme iron is present in the lumen, it gets transported in and it get absorbed. But it is not the same for non-heme iron. If 20 to 30% of heme iron is absorbed, only 2 to 8% of non-heme iron available in diet is absorbed. That is because it has to be first converted into the ferrous form and then taken up by the divalent metal transport 1. So once the iron enters the mucosal enterocytes, it is then stored as ferritin. And from there, it is released into circulation through a transporter called ferroportin. Now, this ferroportin molecule is important because this is a molecule which is not only present in the enterocyte, but also in every storage cell, where this is the only way out for iron from inside to outside of a cell. So once it comes out, it is again transformed into Fe3 plus by hephaestin, and this iron is then bound to transferrin, which transports iron through the blood circulation and delivers iron to the marrow where erythropoiesis is occurring and for storage into the liver. Once the storage pool of liver is completed and filled up, the liver has tendency to secrete this enzyme called hepcidin. Now, the interaction between hepcidin and ferroportin is of very major importance, because this interaction is very significant in our population of interest, CKD. And hepcidin has this action of inhibiting ferroportin, thus preventing iron present inside cells, not only enterocytes, but every cell in the body, and prevents it from coming out of the cell. So it traps the iron in the storage state. And it is important because this hepcidin molecule, which is secreted, this is a peptide secreted by the liver. And in case of inflammation and infection, because of increased IL-6, the levels of hepcidin can increase. And hepcidin is cleared from the body by the kidneys. So when the nephron mass decreases in cases of CKD, the hepcidin level rises. And as you all know, this again, CKD is an inflammatory state, so that itself can cause a rise in hepcidin. And these are the reasons why we say that oral iron is not a good choice for treatment of anemia, because the body is having high hepcidin state, and the chances that the oral iron gets absorbed into the body is fairly less. So as I said earlier, ferroportin is important for transport of iron from the intestinal enterocytes to the serum, also from the splenic macrophage into the serum, and also from the liver, from the hepatocytes. If the iron has to be released, it has to be released through ferroportin. And all these steps can be inhibited by hepcidin if the hepcidin levels are high. So anemia and iron deficiency in CKD. So anemia is almost a universal feature, especially in the later stages of CKD. And in the early stages, about 20 to 62% of the patients might be having significant anemia. Why anemia is a problem? Because it gives rise to morbidity and mortality. Now, in the ester years, in the 1900s, and in the early 1900s, whenever a patient developed CKD and developed anemia, the treatment at that time was blood transfusions. And as you all know, when you give blood transfusions, you are not only giving blood, but you're also giving iron. So in the ester years, there was never a problem of iron deficiency in CKD patients because most of the CKD patients will be already iron overloaded. But then came the era of erythropoiesis stimulating agents. So then, as soon as this came, the need for blood transfusions decreased, and then the iron deficiency became more prominent. So iron deficiency is a problem which arose in CKD populations after the development of the discovery of erythropoiesis stimulating agent. Anemia in CKD, yeah, it is multifactorial. As the nephron mass decreases, there is decreased production of erythropoietin. Decreased erythropoietin, so there is no bone marrow synthesis, and also the uremic toxins further inhibit further production of blood cells from the bone marrow. And if at all blood cells are produced, because of the shorter lifespan in the uremic environment, the red cells undergo senescence, and there is a lot of blood loss either from the GIT or through drawing for blood investigations. There is blood loss, or also during dialysis there is blood loss. Another important thing is it is an inflammatory state, CKD. So there is increased expression of hepcidin from the liver. And hepcidin is supposed to be cleared by the kidney, but since the kidney renal mass is reduced in CKD, there is reduced renal clearance of hepcidin, and hepcidin loiters around. The hepcidin then prevents, inhibits ferroportin, and there is decreased the release of iron from the intestine as well as the storage system. So there are multiple causes of anemia, and this iron part is the topic of discussion for today. Clinical features of iron deficiency: fatigue, shortness of breath. Patient can develop palpitation, pallor, and in severe cases, you can develop flat nails, spooning of nails. Usually, iron deficiency comes along with clinical features of other nutritional deficiencies like B12 deficiencies, B complex deficiencies, and some dialysis patient might present with some rarer symptoms like restless leg syndrome. Then you are supposed to suspect iron deficiency. In a normal hemogram, you can, if the iron deficiency is severe, you can detect it with the help of iron indices, where you can look at MCV, which is less than 80, or RDW, which is more than 14.5. And whenever a dialysis patient or a CKD patient on your follow-up is not responding properly to your erythropoietin stimulating agents, then again you have to think about iron deficiency. So for the evaluation of iron deficiency, there are two set of investigations like ferritin and transferrin saturation has come up. Now ferritin has survived the evolution, I should say, because ferritin is the storage form of iron even in the prokaryotes. In the bacteria, in the prokaryotes itself, also ferritin is the main storage form of iron. And it can be measured in 2 units, nanogram per ml and microgram per liter, and both has the same numerical value. And the next thing is iron and transferrin binding capacity, the total iron binding capacity. So this total iron binding capacity indicates the level of transferrin. And with this, we can calculate what is called as transferrin saturation. So based on these two values, we are able to classify iron deficiency into two. One is absolute iron deficiency and relative iron deficiency. Absolute iron deficiency is a state of low transferrin saturation and low ferritin. So if you could put it in another term, that is systemic iron deficiency. And there can be and it can be due to decreased iron absorption or blood loss, uremia-induced platelet dysfunction, iatrogenic loss from serial blood draws, access site problems, circuit problems during dialysis, all can give rise to systemic iron deficiency. Now, relative iron deficiency is different. It is characterized by low TSAT and high ferritin. It is now termed as iron-restricted erythropoiesis. And the reason is chronic inflammation and infection, which is triggering IL-6 and increased expression of hepcidin and decreased clearance of hepcidin, which then inhibits ferroportin. The same scenario can arise in a different setting. that is iatrogenic. For example, if you are treating a patient with erythropoietin, with exogenous erythropoietin, then there can be a situation when the available iron is used up so fast that the existing iron stores are not able to release it. So there is a demand and supply mismatch, which again can produce a similar situation. And why is it? Why identifying iron deficiency in CKD is important? As I told earlier, there is definitely poor quality of life. And the second thing is treating anemia in CKD is costly, especially the erythropoietin stimulating agent. They are costly, and it has their own problems like hypertension, thrombosis has been described, CVAs, DVTs, vascular access problems, and also adverse cardiovascular events have been described with ECI use. So that's why probably KDIGO came up with guidelines where they stressed upon iron therapy to correct anemia, along with the ESAs and blood transfusion and other latest molecules like prolyl hydroxylase inhibitors. So the problem with the KDIGO guidelines is in 2012 it was released. Then there has been a draft which has been published in November 2024. But it has to be the proper guidelines. We are expecting it in 2025, but not yet published. But we have had a chance to look at this November 2024 draft. So my presentation is mainly based upon November 2024 draft, so that it gives us the latest information of what is going on. So as you all know, all the KDIGO guidelines have strength of recommendation and quality of evidence. So this is how it will be reported. So KDIGO says that test for anemia whenever you get the patient at the first time. At referral itself, make sure you test for anemia. And also when the patient comes up for follow-up, when anemia is suspected based on symptoms, you have to test for anemia. And KDIGO suggests using these investigations: complete blood count, reticulocyte count, ferritin, and transferrin saturation. And in an area, they have mentioned that in low-income countries, at least make sure that a complete blood count with indices are done, so that you can identify, with a thorough clinical examination, you can identify subtle signs of iron deficiency anemia. And the KDIGO suggests that in CKD grade 3, at least annually, the patient has to undergo evaluation for anemia. And CKD stage 4, at least every 6 monthly, and no dialysis population, and CKD stage 5 every 3 months, at least. And if the cause of anemia is not evident with basic tests, then KDIGO says that you can extend your investigations with peripheral smear, stool examination, CRP, liver function test, and other workups. So it is not uncommon. Even we might have come across cases where we evaluate anemia of a CKD patient and finally find that it is actually a case of multiple myeloma or a case of severe hypothyroidism. So these investigations are also told by KDIGO to be done if the cause of iron deficiency is not evident initially. And also further evaluation would require, if anemia is diagnosed, then the next set of investigation that they suggest is serum ferritin and transferrin saturation. As a practice point, KDIGO suggests that if a serum ferritin of less than 45 is found, then you have to work up for evident or occult cause of GI blood loss. And in that case, you have to depend on your colleagues, the gastroenterologist, the gynecologist, urologist. Many a times, we all might have stumbled upon cases of bladder cancer or lower GI cancers or upper GI cancers presenting as severe anemia in CKD patients. So in a KDIGO says that in a CKD patient not on dialysis, if the ferritin is less than 100 and the TSAT is less than 40, or if the ferritin is between 100 and 300 and the TSAT is less than 25%, consider a trial of iron. And the choice of what form of iron to be used can be oral or IV. Now, the reason why the KDIGO suggests that could be due to the thing called a FIND trial, FIND CKD trial. So this trial was done in CKD patients not on dialysis, and it was published in 2014, where oral and IV formulations of iron were used to treat. And the IV formulation group was divided into low dose and high dose with different ferritin targets. It was conducted in sometimes in almost 20 countries. Follow-up was done after 56 weeks. And the final thing was the quality of life and adverse events were similar. So this says that IV iron group had a better better response to therapy. Definitely, IV iron, definitely better response to therapy was there. And the mean hemoglobin rise was also high in IV iron therapy. But another thing that which struck in this thing is the oral iron group and the low dose IV iron group were actually comparable. And most of the oral iron group also catched up in the hemoglobin levels by the end of the study. And another trial called as the EVOKE trial, which was conducted in 2015, again in CKD not on dialysis, stage 3 and stage 4. There again, it was studied, and they found that the IV iron group had more cardiovascular events and adverse events at the end of the study. And the study was terminated early because of the same reason. So this again shows that even though KDIGO says that oral and IV iron both can be chosen, there is still a role for oral iron in cases of CKD not on dialysis. Then anemia in CKD treated with hemodialysis. So in a patient who's a patient who's on hemodialysis, the ferritin is less than 500 and TSAT is less than or equal to 30, then iron therapy is indicated. And they give a 2D recommendation. And they say that if the patient is on hemodialysis, the better route of iron administration is IV iron rather than oral iron. And this administration should be done in a proactive approach. So this practice point probably came up. The proactive approach practice point probably came up by the pivotal study. The pivotal study was a multi-center study where adults with CKD on hemodialysis were selected, and all of them were having ferritin less than 400 and TSAT less than 30. And they were on erythropoietin stimulating agents. They divided them into two groups. One is a reactive group, where the patient would or would not get IV iron from up to 0 to 400 milligram IV iron sucrose monthly. And it will be given only if the serum ferritin falls below 200 or TSAT fall below 20%. And the second group, the proactive group, they were given monthly IV iron sucrose for about 400 milligram monthly. And the therapy was withheld only if the ferritin rose above 700 or TSAT rose above or equal to 40%. So what they found was the proactive group, the requirement of ESAs were very, very few. And primary composite endpoints like non-fatal MI, non-fatal stroke, hospitalization for heart failure, death, everything was low in the proactive group. So the proactive group ended up receiving a lot of iron extra than the reactive group. So we had always this notion that treating iron in an excess would create problems. And there was no much problems. The proactive group kept on giving iron till the ferritin was more than 700 or TSAT more than or equal to 40. So that may be the reason why this particular approach of IV iron was chosen. Then what about supplementing iron when serum ferritin is high? So this is what was discussed in pivotal. And the proactive group, there was no much infectious complications or CV complications in the proactive group. And similarly, there were two other trials like DRIVE-1 and DRIVE-2 trial that also was done in dialysis dependent CKD patients, where the TSATs were less than 25, but the serum ferritin levels had gone up to even 1200. So that gave a safe haven, safe path for choosing IV iron and IV iron in excess in CKD patients on dialysis. Now, if the KDIGO says that if a patient with CKD is treated with oral iron, which formulation of oral iron to be chosen? It can be chosen by discussion based on cost, individual patient preference, tolerability, or efficacy. The different oral iron formulations are there, of which you can say that the ferrous sulfate form, it has an elemental iron of around 65 milligram per tablet, and it has to be given at least 2 to 3 times a day. And these are some of the newer iron population like the liposomal iron, which is ferric pyrophosphate. And the thing is that it can be given as a single tablet per day. And there are other ferric other iron formulations like ferric citrate, which also has additional property of binding phosphate binder, along with iron correction. So sucrosomal iron, as I told earlier, it's a ferric pyrophosphate molecule, and it has a phospholipid bilayer with a sucroester matrix. The different thing regarding sucrosomal iron is that it is not absorbed in the proximal small intestine, but instead it is absorbed at the distal small intestine near the Peyer's patches. So the absorption is better because of the phospholipid bilayer through the Peyer's patches, and about 30 milligram of iron can be delivered. And it's an over-the-counter medication, and only once a daily dose is required. Now, KDIGO says that if you are using IV iron for the correction of anemia in CKD, then which formulation to choose, that again depends upon individual patient preferences, dosing schedules, the cost. But it definitely says that if the patient is treated with iron, you have to consider withholding iron therapy if serum ferritin is more than 700 or TSAT is more than 40. So this recommendation again would have come through the findings of the pivotal trial, which held this target for treating their patients in the proactive group. And why the problem of iron toxicity is a problem? The problem is because of labile iron. The labile iron can generate free radicals which can damage biomolecules. So this is called as a catalytic iron. So earlier I told that iron can undergo this redox reaction, of which the Fenton reaction is a particular reaction where iron can donate electrons and create free radicals. Just like our body requires iron for its requirements, microbes also love iron. Whenever iron is given in a scenario where there is active infection, it can exacerbate infections. And KDIGO also says so. KDIGO says that as a practice point, that whenever there is active infection going on, it is better to withhold IV iron or oral iron supplementation. And we know that whenever iron deposits in toxic levels in different tissues, it can create problem. And it can even deposit in non-transferring carriers that again can create problem. We are exposed to this group of patients when dealing with hemochromatosis and thalassemia patients. So we see iron overload creating problems for them in the liver, in the heart, endocrinologically and all. So when to check response? In CKD patients on hemodialysis, the response should be checked monthly. And CKD patients not on dialysis, at least every 3 months. And the investigations that KDIGO suggests is hemoglobin, ferritin, and transferrin saturation. And KDIGO says that if frequent testing is required, and more frequent testing is required in certain set of patients, when there is initiation or an increase in iron dose, then there is episodes of known blood loss, recent hospitalization, or when the recent serum ferritin and transferrin saturation levels were very high. And KDIGO says that when you don't see a response in 1 to 3 months of giving oral iron, then you are justified in switching over to IV iron. So as I told earlier, IV iron has its own problem, and that is because of the release of labile iron into circulation, the catalytic iron, and can give rise to hypersensitivity reaction. So while prescribing iron, KDIGO says that make sure that you have the facilities to manage an acute hypersensitivity reaction or a hypotensive episode if it arises during your therapy. So it should be given in a proper setting in a hospital where this scenario can be tackled. And they say that never to exceed the maximum dose per administration for a particular compound when you are prescribing it. And earlier pre-medications were indicated, but now it is not required. And earlier test doses were needed, but the current formulations doesn't require any test dose. So what are the iron reaction, hypersensitivity reaction, non-specific symptoms? Chest tightness, giddiness, lightheadedness, nausea, itching, asymptomatic hypotension. KDIGO groups these as non-specific symptoms, and whenever this happens, KDIGO suggests that you stop the infusion, observe for 50 minutes, then restart at 25 to 50% rate. And if it recurs, then stop. Mild infusion reactions are non-specific symptoms along with urticaria. So in such cases, you stop the reaction, you retrial it after a dose of steroid or steroid and H1 blocker. And if it recurs, then you are not allowed to continue. Moderate reaction occurs when severe chest pain is indicated, along with cough and tachycardia. There, you have to stop the infusion, treat with IV fluids, IV steroids, H1 blockers, and consider an alternative preparation and discuss the benefit and risk of that with the patient. But when you are facing stridor, cyanosis, wheezing, hypotension, tachycardia, that is a anaphylactic reaction. You have to immediately stop the infusion, IV fluids, oxygen inhalation, IM adrenaline, IV steroids, nebulization for the bronchospasm. We have to admit the patient, and future IV iron cannot be tried in such patients. So the hypersensitivity reaction, as I told earlier, is due to the labile iron moiety. And initially, when the iron oxide preparations were available, it was very rampant, very severe reactions were witnessed. But now we have formulations, IV formulations, which are a colloid. And these colloids are made up of an elemental iron, which is held inside a carbohydrate shell. And the carbohydrate shell can be different. It can be dextran, sucrose, gluconate, maltose, isomaltose. And with this arrangement, the in reactions, hypersensitive reactions have drastically come down. Especially the newer molecules, the hypersensitive reactions are very less. It is told that ferric pyrophosphate citrate and heme iron polypeptide, which are the newer, latest forms, no hypersensitivity reactions have been recorded till date for these formulations. So you can see how we have been improving, upgrading ourselves in the IV iron compartment, where nowadays the formulations deliver more iron in a single dose. Initially, we used to use just iron sucrose. Now, ferric carboxymaltose is available, where you can give up to 750 milligram per dosage. And now the latest iron isomaltoside, you can give up to 1000 milligrams per dose. And because of this, we are able to cut short the hospital requirement of the patient, and with very fewer doses, we are able to attain the required response. Now, KDIGO says that there is a population where there is no anemia, but the ferritin is very low and the TSAT is less than 25. Are you justified in treating? Yes, the KDIGO says yes, and you are justified in treating with iron therapy. And this observation comes from the fact that iron has many non-anemia kind of roles. It is essential, as I told earlier, for many other things, and that is the reason why it is indicated in cardiovascular strain, impaired muscle function, impaired exercise tolerance, performance, altered immune function. Even for the proper development of a pregnancy and the fetuses, proper levels of iron is required. So whenever there is no anemia and the levels are too low, where the ferritin is less than 30 and TSAT is less than 20, you are justified in treating iron deficiency. So this is one patient. So this is one patient, analysis patient who had, sorry, the videos. Okay. So this was one dialysis patient who had restless leg. So which on evaluation actually came into this category. This patient had no anemia. The patient was having actually a ADPKD, and the hemoglobin was like 13.5, 14 like that. But his serum ferritin was less than 30. TSAT was less than 20%. And patient presented with this symptom. So we tried ferric isomaltoside because it was a single dose we could give. We tried that, and that symptom resolved. Initially, he was treated with some drugs by the neurology team, but within 1 to 2 weeks itself, the symptom completely resolved. That was a case of restless leg syndrome presenting as iron deficiency. So a few facts about fibroblast growth factor 23, FGF23. So in year 2000, this disease called autosomal dominant rickets was identified. So in this autosomal dominant rickets, they found that the patient was having persistent hypophosphatemia. And that is when they found that there is a, this hypophosphatemia was due to a phosphatonin, which is a phosphaturic substance. And this substance was indeed fibroblast growth factor 23, FGF23. And this FGF23 is secreted by the osteoblast and osteocytes. They act upon the proximal convoluted tubule to cause phosphaturia. It also inhibits alpha hydroxylation and decreases the level of 125 hydroxy vitamin D. It also inhibits PTH. So you can see how FGF23 has effects in the mineral bone disease category of CKD. So whenever there is high phosphorus, FGF23 is secreted. FGF23 will inhibit 1-alpha hydroxylase, decreasing the 125 hydroxy vitamin D. FGF23 inhibits the high PTH produced by high phosphorus. And because of this reason, it causes increased renal phosphorus excretion. Now, of late, some off-target effects of FGF23 were identified, like left ventricular hypertrophy, sudden cardiac arrest, accelerated atherosclerosis, vascular calcification, CKD progression, inflammation. So this went to the new recognition that in patients with autosomal dominant hypophosphatemic rickets, that was the reason why FGF23 was discovered. So this autosomal dominant hypophosphatemic ricket patients developed flares of hypophosphatemia during iron deficiency. They developed worsening of hypophosphatemia during iron deficiency. And another observation was whenever iron chelators was added to bone culture cells, again there was a hike in FGF23 production. And there was another observation that whenever there was high hepcidin states, where the hepcidin levels were high, the iron levels were low, there was a hike in FGF23. And further studies prove that even inflammation and EPO can stimulate FGF23. Now, FGF23 stimulation is bad because of these off-target effects. So, and this connected iron with FGF23. So, the iron deficiency seen in these three conditions indirectly showed that it causes a rise in FGF23. So that is why treating iron deficiency is important, and it helps in lowering FGF23. And it was found that ferric citrate, oral ferric citrate, which is an iron supplement, which also has a phosphate binder action. In patients treated with ferric citrate, the levels of FGF23 were actually very low. And another observation was when patients were treated with ferric carboxymaltose. Ferric carboxymaltose is a iron preparation where you can deliver almost 750 milligram of iron per dose. It's a third generation IV iron. It is mainly made up of ferric oxyhydroxide, and it is surrounded by a carboxymaltose shell. And it is approved by FDA in 2013. But what they found was the patients treated with ferric carboxymaltose, if the patient was already a bit on the low phosphorus side, they developed a hypophosphatemia, and some of them even developed fractures and osteomalacia. And that is when this description was done and found that the carbohydrate moieties of ferric carboxymaltose has high propensity to prevent the cleavage of FGF23. FGF23 has to be cleaved and removed from circulation. FCM, the ferric carboxymaltose's carbohydrate moiety, has the propensity to prevent this cleavage, thus raising the levels of FGF23. This causes increased phosphaturia, urinary loss of phosphorus, thus reducing the serum phosphorus. And since FGF23 inhibits 1-alpha hydroxylation, the levels of 125 vitamin D3 also comes down. This gives rise to a low levels of calcium, which again triggers hyperparathyroidism. This was something what is called as the 6H syndrome. 6H syndrome. High FGF23, hypophosphatemia, hyperphosphaturia, hypovitaminosis D, hypocalcemia, and secondary hyperparathyroidism. And it was found that the incidence was almost 40% in patients with ferric carboxymaltose. And that is when that is where the role of iron isomaltoside comes. Now, iron isomaltoside was US FDA approved in 2020. It is made up of a ferric oxyhydroxide with a der-isomaltoside carbohydrate moiety. Now, this der-isomaltoside carbohydrate moiety is linear and unbranched, and it has got less propensity to cause 6H syndrome. And it was again proven in studies like Ferron-Nephron study. And these are different formulations of the newer formulation of iron, ferromoxitol, ferric carboxymaltose, ferric der-isomaltoside. Ferric der-isomaltoside is the same as iron isomaltoside. You can see that the propensity of ferric carboxymaltose to produce hypophosphatemia is close to 40%, and it was much less in ferric derisomaltoside or isomaltoside, iron isomaltoside. And the newer latest molecule, ferromoxitol, has got very less chance of producing this. And that is why derisomaltoside or the ferric isomaltoside is considered superior to ferric carboxymaltose. The problem is the cost, which will slowly come down as we see in the future. Now, just mentioning this interesting molecule called ferric pyrophosphate citrate. Now, this molecule, the specialty is this molecule can be given as an infusion during dialysis itself in the bicarbonate solution or even in the heparin syringe that you give for the patients during dialysis. It's water soluble. And the special thing regarding ferric pyrophosphate citrate is that usually when you give an iron, IV iron, the IV iron molecule will release iron, and the iron released is taken up by the reticuloendothelial macrophages, and then from that macrophages it is transferred to transferrin. Now, the special thing regarding ferric pyrophosphate citrate is that the molecule directly releases the iron directly to transferrin. So it is entering the circulation very fast. And transferrin as a carrier molecule prevents the labile iron effect in circulation by capturing it and delivering it to places where it is required. So by this, you can circumvent the hepcidin bridge, because if the hepcidin levels are high, the release of iron from reticuloendothelial macrophages to transferrin is obstructed. So by this particular molecule, you can bypass the hepcidin bridge and directly transfer iron to transferrin. Now, the few words regarding CAPD, iron deficiency in CAPD, I couldn't find anything more. What it says that iron loss during for a patient in hemodialysis per year is around 2.5 to 3 grams per year. And iron loss in CAPD is only 1 gram per year. So usually CAPD patients, anemia may not be a problem for them if they are having good nutrition and everything else. So whenever, if at all you see a patient with CAPD with anemia and it's due to iron deficiency, then you are justified in treating it with oral or IV. And this decision can be based on that particular patient and the particular scenario. Again, an oral trial of iron is not a problem at all. And it is has been studied and verified in different RCTs that there is no increase in infection with iron therapy in CAPD patients. There is no increase in peritonitis. There is no increase in exit site infection. But as KDIGO says, in cases of active infection, always withhold iron. Few words on iron deficiency in post-renal transplant patients. Now, according to literature, about 30 to 52% of patients post-transplant can be iron deficient. And the reason is that it is an inflammatory state, high hepcidin state, and most of the time the graph may not be fully functional. So there is a component of CKD that again is a high hepcidin state. And it is said that mTOR inhibitors also stimulate levels of hepcidin. And many times when the graft is not fully functioning, the renewed erythropoietin production may be deficient. And also in female patients post-transplant, once they restart menstruation, that again becomes a new cause of loss of iron from the body. And oral iron can decrease absorption of MMF. So many times oral iron is not routinely prescribed. And IV iron decreases. And that is the reason why when you want to correct post-transplant anemia, and due to iron deficiency, it's better to give as iron formulation, which decreases the pill burden and decreases drug interactions. So the take-home message is iron deficiency is there to stay until we are going to treat CKD with erythropoietin stimulating agents. Iron deficiency will be there and will be faced by us. But the problem is detecting it earlier so that it doesn't create a problem to the patient, and treating it earlier. And for that, the KDIGO has given us a rough draft of ideas, and hopefully we get a definitive guideline this by around 2025. And when you treat it adequately, the ESA requirements comes down. As the ESA requirement comes down, the cost of therapy comes down. And finally, once the anemia is corrected, it increases the quality of life. Okay. Thank you.